after that wonderful talk by Dr. Balkrishnan and, of course, pioneers in heart transplant, both Dr. Balkrishnan and Dr. Anvay Muley, I think my talk is on Impella, Impella, basically Impella Assisted PCI. So this is the high-risk patients with complex coronary artery disease are often a complex anatomy to treat, and we have a lot of issues when we manage these patients. So basically, there are a lot of patients, high-risk patients, who are subjected to higher mortality, suboptimal results, suboptimal treatments. And when we try to improve these revascularization outcomes, very often we require some support. And we know that in patients who have a good load in these, a way of a good road to recovery, I think doing something can help these patients to come out of their present predicament. So these are the, if I were to make it short, in patients with coronary disease, you have medical management or you have revascularization. Amongst those, in patients with high-risk angioplasty or with bypass surgery, you have to use some form of support, either an intra-aortic balloon pump or a Impella. There are certain indications where an Impella would be more advisable. There are certain indications where an IBP may help. An Impella 5.5 is no longer available in this country. Amongst the patients who undergo protected PCI with Impella are those patients with heart failure, surgical ineligibility, prior cardiac surgery, and high-risk renal insufficiency, multivessel disease, left main disease, and of course, severely compromised LV functions. So these are the subsets of patients who require some form of support. This is an India clinical expert consensus which came out in 2022. Which basically helped us to, in many ways, to assess patients for the use of supports. And in one of the ways was to use a scoring system based upon the hemodynamic status, the patient characteristics, coronary anatomy, and procedural characteristics, and a score of less than 3 to a score of more than 5, where it strongly considered support as one of the basics in any of these interventions. I'm going to present to you a patient one of the patients we did, who happened to be a 65-year-old gentleman who had flown in from out of town with an anterior wall infarct and poor LV function. By the time when we saw him, he was on multiple supports, on milrinone, breathless at rest, not able to get out of the bed. And these were the scores: the Syntax score of more than 32, and the risk score here of more than 6. And he was actually listed by our heart transplant team for a heart transplant, and but he was getting worse. So then we decided that we'll do something about the coronary anatomy. The reason why we used a Impella support was these factors: LVF was about 20%, acute coronary syndrome recent, the creatinine was on the higher side, and of course he was a surgical turned-on candidate. This was the parameters when we took him up for the procedure: the BP of 90 systolic, and LVF of 22%. Now this was, of course, this is the Impella. We decided to go upfront on the Impella. I'll show you the angiography findings and the reason why we went upfront with the Impella in this situation. And this was the coronary angiographic finding. You can see that it's got a critical left main disease, totally occluded LAD, heavily calcific vessels, calcific circumflex, dominant circumflex. So this was a situation where we would definitely like some support on this. So what we did in this situation was, after institution of the Impella support, and we involve our heart transplant team in the Impella decisions and the Impella placement also. So they are there who are hand-holding us throughout the procedure. So what we did in this was to treat there was a large diagonal. So we decided to treat from the left main into the large diagonal first, get a good assessment of the diagonal. So we did a rotablator for the LAD into the diagonal. Once we did that, we took out the wire from the circumflex, and we had to rotablate into the circumflex because we can't rotablate keeping a wire in the left main there. So rotablated the circumflex. Once we got a decent support, a decent result, we went ahead and dilated the diagonal, stented the diagonal into the LAD, and subsequently used a NSC aperta balloon for the circumflex because the cutting balloon wouldn't cross. and subsequently also an OPN NC balloon, a cutting balloon for the ostium of the LAD and the left main. And you can see, and this was done under IVAS guidance. We had an IVAS, I've not got the images on this. Subsequently, we used a mini crush, a stent to the mid circumflex and a mini crush to the osteoproximal circumflex and the left main, and did a pot to the left main with a 4.5 into 8 millimeter balloon subsequently. Again, recrossed, did a proper kissing into both the vessels, and a pot again. And this was the final result where we left him. And we managed to decannulate the Impella on the table itself. This was the systolic parameters after the procedure. And a couple of days later, we found the LV ejection fraction had improved to about 25%. Now, this is one factor which I want to show you on this, and that is called as ventriculoarterial uncoupling. And that actually happened during this procedure, where every time we dilated a balloon or did anything to the circumflex lesion, we had a complete uncoupling of the ventriculoarterial trace, which means that the LV pressures have fallen below the aortic pressures, and the aortic valve no longer opens, and the circulation is completely maintained on the Impella in this. So this is a trace where you can see that the red trace, which is the aortic trace, is completely a straight line. So this is basically the reason for ventriculoarterial uncoupling, where the LV is unable to overcome the afterload of the aorta, creating an uncoupling. And post-procedure, and post of the dilatation, the tracings came back, and we maintained the same. Of course, we removed the Impella on the table and closed the vessel with two percloses. And this was the, I'm sorry, I won't say the residual syntax score was 0. It was, we did not achieve a complete revascularization, but the distal LAD was totally occluded. So whatever we could revascularize, we got a good result on that. Now, follow-up at 8 months. He came back for a follow-up to the clinic at 8 months, flying back from his hometown in Raipur, where he is absolutely fine. He doesn't even think of the heart transplant now. He doesn't want any procedure. He's roaming around doing everything absolutely normal. His LV ejection fraction has improved to 35%. So we do know from the series of studies that there are certain situations where mechanical assist devices will be helpful, and they have been proven to be beneficial in reducing the major clinical events at the end of 90 days. The PROTECT 2 was one of the early studies which showed that there was a 29% reduction in the MACE in these patients. The PROTECT 3 also showed that there's an improvement in those patients who were subjected to the use of Impella. And the recent danger study also proves that point, though it also showed that we need to be careful in implanting these devices, because the complications associated with the Impella are significantly on the higher side if they are not properly dealt with. Definitely, there's a quality of life improvement in protected PCI patients, as shown on the slide in the PROTECT 2 studies. And overall analysis of different studies basically showed that in terms of the LV ejection fraction at different periods of time, there has been a significant improvement in those patients who have been done a procedure with assisted mechanical supports. A significant improvement in heart failure and angina-like symptoms in patients used with MCS devices. And near normal ejection fraction, again, heart failure symptoms and anginal symptom improvements, which are shown in the RESTORE EF study. In those those patients were classified to the use of Impella. Again, when you have a support system, your revascularization is far more superior and far more complete, because you are not worried about the hemodynamics. You tend to take your time and improve the overall procedure, because you're not looking at the rhythm and looking at the patient's cardiovascular status. The PROTECT 2 study also showed that there was a 47% reduction in the post-discharge MACE events and a continuous safety improvement over time in high-risk PCIs. These are certain guidelines that are available for Impella heart pumps. Guidelines are there to guide us. They are not the gospel. So I think every patient has to be taken in its completeness when we recommend any of these devices, mixing the advantages, disadvantages, and the complications involved. Impella enables complete revascularizations in patients with ACS, very low EF surgical turn down in a single setting. Staging the procedure can be avoided. In patients with particularly acute kidney injury, I think an Impella definitely gives you an advantage in terms of maintaining the circulation. Less hypotensive events. Do not hurry to explant on the table if the procedure time is long and anticipating unstable hemodynamics. And the AIC trend screen is extremely helpful to access the right time of weaning. And I always reiterate this, that this is a multidisciplinary approach. When we're dealing with the Impella and other devices, I'm sure people who are more experienced with these devices should be there to lend a hand. And I think that helps in the overall outcomes. Thank you very much.